This past year has brought horrifying headlines of senseless violence involving children. These isolated events may represent only the tip of the iceberg. As pediatricians, we are all concerned about identifying and providing resources to our patients regarding this issue. Dr. David Schonfeld is a developmental and behavioral pediatrician and director of the National Center for School Crisis and Bereavement at St. Chris's Hospital in Philadelphia. He is a member of the AAP Disaster Preparedness Advisory Council. The goal of the National Center for School Crisis and Bereavement is to promote an appreciation of the role schools can play in supporting students. All of this in support of staff and families at the time of crisis. In addition, the center collaborates with other organizations and agencies to further this goal. Dr. Schonfeld has published extensively on this issue, and today we'll discuss how we can better address this important topic in his presentation, Aurora, Newtown, Boston, and Beyond, Violence and Its Impact on Children. Dr. Schonfeld.
Well, good morning. I'm going to start with I have no disclosures. And my goal for the presentation this morning is to highlight selected aspects of the impact of violence on children. And I'm going to start by illustrating a couple findings from animal research involving rats. Then I'm going to underscore why this should be seen as highly relevant to all of us, well beyond the natural empathy we all have for traumatized rats. And then offer some suggestions about what we can do to improve the situation for the children and families that we serve. So let me start by illustrating some of the relevant research findings. In one set of experiments involving rats, investigators identified a normal distribution of maternal nurturing behavior in these rats. Infants raised by mothers that provided a higher level of nurturing, as demonstrated by more licking and grooming behavior, actually had infants who were less fearful, less reactive to stressful situations, and performed better on several tasks that were felt to be dependent on the optimal functioning of the hippocampus. In related research, it was demonstrated that by cross-fostering infant rats from mothers who provided less of this nurturing in one experimental study, and then having them raised by foster mothers who provided more nurturing behavior, these foster mothers were able to compensate, demonstrating that caregiving and support of other adults, even outside of the family, can help to promote the development and adjustment of children impacted by a crisis. Now, these research findings are directly applicable to humans. Data from a cohort from the National Collaborative Perinatal Project actually demonstrated that there is the same distribution of maternal affection provided to human infants, and they showed this at 8 months of age as measured by observations of maternal behavior during cognitive and developmental testing in the laboratory. And they actually showed that the degree of maternal nurturing in this experimental setting predicted the emotional distress when these infants later became adults. So the question is then, how does maternal nurturing have such a lasting impact on emotional distress in offspring when they turn to adults? It appears that this high frequency of nurturing behavior during a critical period of brain development is actually necessary for the removal of DNA methylation from the promoter element of DNA that controls the expression of the glucocorticoid receptor in the hippocampus. And this, in turn, controls the rate by which the release of corticosterone in the rat after a stressor is terminated. Rats, therefore, raised by mothers, according to this model, had higher rates of expression of the glucocorticoid receptor in the hippocampus, and therefore, in turn, had shorter periods of exposure to corticosteroid after experiencing stress. Of particular interest, once established, this pattern of DNA methylation is actually stable. And in this way, an epigenetic phenomenon can explain how early parental nurturance can result in less stress reactivity in offspring in adulthood. Recent research actually involving post-mortem analysis of human brains from adult suicide victims showed that those with a history of early life adversity also had lower levels of glucocorticoid receptor messenger RNA in their hippocampus and higher rates of DNA methylation in the same promoter region that was found in the rat model. Now, there's a whole separate and growing body of research which has also demonstrated that chronic severe stress, especially during critical periods of brain development, leads to long-term changes in brain function and structure. Now, if you take all of this research together, it underscores the need to protect children from stressful situations as much as possible, to intervene quickly after stressful events occur, and pay particular attention to minimizing subsequent stressors because of the particularly detrimental effect of chronic stress on children. And we should also appreciate the role other supportive and nurturing adults can play in mitigating the impact of trauma. Now, the research that I've referenced and much of the clinical work has actually focused on the impact specifically of trauma on children. But I would like to caution people that children's adjustment after these events, whether they be traumatic events or not, relates also to what occurs as a result of the event. For example, for those who experience the death of a family member through a violent situation, their predominant problem may actually be due to bereavement. I remember going out to Aurora several weeks after the shooting occurred in the movie theater. And I went to the home of one adolescent who was reluctant to return to school and had declined any offers of trauma counseling. And he was refusing phone calls, so we went and visited him at home. And what he explained to me was that he didn't feel the need for any trauma counseling. It turned out that individuals on either side of him were shot and killed in the movie theater, although he was not hit by a bullet that evening. But he said it happened in the dark and he was pulled out well before he even knew what was going on. He had had some trauma symptoms, some difficulty sleeping. He was very fidgety and reactive, but he said that that had abated within the first week, and he was actually going out with his friends that were in the movie theater at the time. But what he reported was that he just still didn't feel right, and he felt very sad and quite empty. And one of the people who was murdered was a close friend that he had grown up with. So I suggested perhaps his problem was more bereavement at the death of a friend of his, a childhood friend of his. And at that point, he just looked at me and he said, "That's it. And if you can get me counseling for someone that'll talk about that, I will go to it. But I don't want to talk about the shooting." The point that I was struck with was that no one had actually offered or suggested that bereavement might be an issue for him, despite his friend being murdered. And I've seen this in crisis event after crisis event when I've responded. It's also not just bereavement. In crises generally result in a cascade of secondary losses and stressors, and any one of them may actually be the cause of the child's difficulty. Now, as I was thinking about preparing for this presentation, I remembered that I last spoke at this plenary in 2001, about a month after the events of September 11th. And I'm back now talking about essentially the same topic. But one thing that I noticed was a change was the titles. I hadn't actually picked the titles for either of the presentations, but the title in the first talk dealt with 9/11. The title for this talk is actually a list of traumatic events that have happened recently, and it's an abbreviated list, and it's actually already out of date. So I am struck by the fact that it seems that there are more stressful events that children are faced with. When I was responding to the event in Sandy Hook, I noticed that there were a lot of people who thought this was a very unique and horrific event, and it was a very horrific event. But I asked people why they thought this one was so much worse than all of the ones that preceded. And what I was consistently told was it was the first time that it involved such young children and happened in a community that was uncharacterized by any violence. But it's actually not the first time that that's occurred. And I'm sure many of you remember in Nickel Mines, Pennsylvania in 2006, a similarly horrific shooting that occurred in a one-room Amish schoolhouse. 10 girls ranging in age from 6 to 13 were shot at close range, execution style. Actually, 2 of the older girls offered to be shot first so that he would spare the other children. In fact, he shot all of them. And half of the children died as a result of their injuries. 3 of them were only 7 or 8 years of age. And there really isn't a place less characterized by gun violence than an Amish schoolhouse. Now, although the country and the world were shocked by that event at the time, it seemed to me, at least, that that rather quickly left people's awareness. We know one other person who remembered that event well, and that was the shooter at Sandy Hook, who actually apparently read about and identified with the shooter at Nickel Mines and aimed to emulate him. Now, I'm concerned that these events are in some way becoming more common. I was doing a presentation for Aurora Public Schools as they were approaching the first anniversary of the shooting that happened in the movie theater there. And I was raising the point that sometimes it's very hard for teachers to be acknowledged to be heroes because of really the heroic acts that they make to try and save the lives of children during these events and to support them. And that it's hard to feel that you're a hero when children die. And one of the teachers, as I was leaving to go to the airport, came up to me and thanked me for the comments. And she told me how helpful that was to her and how she had wished she had heard that a long time prior because she had struggled with those same guilt feelings. And I wondered why she said that until she clarified for me that although she taught in Aurora Public Schools, she had prior taught at Columbine. So the issue is, I realize these are rare events, and they are in some way like lightning strikes in terms of their frequency. But I'm starting to run into people that have been struck twice. And I'm beginning to be concerned that perhaps these events are happening with more frequency, and we should heed that. And we should also be careful not to assume that simply because something is more common or even quite common, that children get used to it. I often hear this comment in communities that are characterized by very high levels of violence and loss, where observers and even members of the own communities say to me, children just get used to violence in this community. And I would say that they don't get used to the violence. They simply learn that there's little benefit in asking for support or assistance from adults in these communities because it is so infrequently offered to them. They may in fact become fatalistic and engage in reactive risk-taking behavior or counterphobic behavior, placing themselves at even greater risk, but they don't get used to it. And I would contend that neither should we. So let me spend the rest of my time outlining some ideas of what we can do about it to try and affect positive change. The first is we need to work to decrease violence, crisis, and loss. And we should advocate for meaningful change. When I was in Connecticut early on in my career, I remember being invited by the Connecticut Commission on Children to speak at a public hearing on gun violence for Senator Dodd. And in the invitation, they clarified to me, don't speak as an expert on the impact of violence on children, and don't speak as a pediatrician, which is an expert on the impact of children on violence. She said, instead speak as a parent. So I talked with my daughter about what the experience was like being in a community where there was urban violence. And she told me her story. And she came with me, she was in the second grade at the time. She came with me to the hearing and stood by my side while I read her story. And I think that's what we should all do. We should give a voice to children who are impacted by these events and force a dialogue that can help move the agenda forward. We should also advocate for better systems and services for children who are impacted by these events, as well as a full range of adversity in the lives of these children. In my own institution at St. Christopher's Hospital for Children, we're in a community that is marked by high rates of urban violence, food insecurity, poverty, and a range of other adverse impacts. And we're in the process of constructing a center for the urban child to try and study this and provide optimal services to this very vulnerable population. Individually, we should all become more skilled in how to support children, whether they be traumatized or grieving. And I'll be doing a session this afternoon on supporting grieving children. We should also ensure that other professionals that are in a position to support children, such as teachers and other school staff, are better prepared, more skilled, and more effectively supported in helping children with these events. But I would argue we shouldn't wait until these events occur to introduce this information. I remember talking to the parent of one girl who was in Sandy Hook, and she was in one of the early grades and had been directly exposed to a lot of the violence. And about 2 or 3 weeks after the shooting, I was on the phone with him providing advice for about 45 minutes. And then at the end of the phone call, he said, you know, this was so helpful to me. I did not get this type of information several weeks ago when it would have been most valuable. And he questioned, why didn't the school actually arrange for someone to come and speak to us then when we needed it most? Why didn't they find someone like you? And I didn't know how to tell him that they had. And I had done a presentation to the entire school staff Monday morning after the shooting that occurred on Friday. Either he was unable to come because he was caring for his family, quite understandably, or also equally likely, he came and wasn't really able to absorb the information. So in the field of disaster work, we often talk about JET, just-in-time training. And what I would argue is just-in-time training is often not in time. So we really need to start to introduce this information early on, well before these events occur. We should also, in our practices, inquire about exposures and experience more routinely. I'm a member of the Project Advisory Committee for the Medical Home for Children Exposed to Violence project that aims to do just that. And in a slide later on in this presentation, I'm going to show you the website for that project, which provides medical home teams with the resources they need to modify their practice operations to more effectively identify, treat, and refer children and youth who've been exposed or victimized by violence. At the time of a particular event, we should notify children promptly and facilitate discussion of the impact of the event. If instead we say nothing about these events, we deliver a very powerful message, that we don't feel that children are able to handle the events, or we don't believe we are capable of providing them support at this time, and neither is a helpful message. Instead, we should provide psychological first aid, offer psychoeducation, attend to their basic needs, and perform timely triage and referral. But remember that we will need to provide these services throughout the recovery period, which may be weeks, months, or years. We can also help in our own community when events happen elsewhere in the country and in the world. Often people want to fly to the scene of a disaster to try and provide direct service to that community. And we all can't do that because we can't be accommodated in a meaningful way there. But there's still a lot that you can do in your own communities to support your patients and your community as they struggle to understand and cope with these events and deal with the distress that surfaces at these times related to their own concerns and their own personal experiences. The reality is you don't have to travel to find adversity, trauma, and loss. You just need to ask the families in your own community and in your own practice, and you'll find it there and be able to make a very meaningful impact. We should also, though, come together and become aware of and support the efforts of the Academy in disaster preparedness and response. The Academy's Department of Federal Affairs has helped to make the AAP one of the leading forces for positive change at the federal level. The Friends of Children's Fund in general, and specifically the disaster relief part of that fund, helps not only children, families, and communities recover, but also assists professionals with self-care after these events. We need to recognize it's distressing to be with children in distress, and that the events that are troubling our patients and their families are troubling to us as pediatric healthcare providers as well. I was doing one presentation at a large conference for educators, and after I finished my session in a large auditorium, people stayed to ask questions of me. And after I finished all of the questions, there was one person waiting in the back of the room, and he had waited quietly for about a half hour. He didn't come forward, so I went back to the room and asked him if he had a question. And he looked at me and said, "No, I don't." And I said, "Well, is there anything I can help you with?" And at that point, he started to cry. And what he then told me that he was the superintendent at a school system outside of the United States, that several years prior had experienced a bus accident that led to about 5 students dying. And he said that it still bothers him when he thinks about it, and he still cries about it. And then he looked at me and he said, "Perhaps I should retire." And I said, "Well, quite honestly, if 5 of your kids can be killed and it doesn't bother you, I would suggest you retire." We need superintendents who actually care whether or not the children survive and are healthy. So the issue is, it's a price that we all pay by caring, but if we don't care, we won't be effective in our work. So I'm glad that the Academy is focusing more efforts on professional self-care, and we're actually hosting a conference next month at Academy headquarters to think more about what the Academy can do to provide support around professional self-care for pediatricians and other healthcare providers impacted by disasters. This slide, which is my last slide, offers some resources of websites where you can get further information. One is the Children in Disasters webpage, specifically the Coping and Adjustment webpage for the Academy site. The second is the Medical Home for Children Exposed to Violence website that I mentioned. And the third is the website for the National Center for School Crisis and Bereavement, which is just schoolcrisiscenter.org. While I leave that slide up, I just wanted to conclude by saying that we should also recognize and celebrate what we have done and continue to do every day in our practices to support children and families that are dealing with difficult situations. It makes a big difference. I don't want you to get overwhelmed by all that could and unfortunately does happen, and the long-lasting and profound impacts these violent events can have on children. Instead, I challenge you for one thing, and that's to commit to at least one strategy to advocate for violence prevention and/or readiness for your practice or your community to support those who have been impacted by these events. And I thank you for your attention.